All right, thank you for joining us for another episode this week of Recovery in 20. This week we are joined by Danny. Danny is a clinician over here at our Lakewood facility, and I was kind of curious about what happens in therapy. It's different for everyone. We do group and individual therapy here, so I just wanted to dig in with Danny and have a conversation about what really happens in therapy, because I'm sure it's different here than where I went, and different in every one of these little rooms. So thanks for joining us.
Yeah, of course. And yes, it is different, right? If we're all individuals and we have different things that make us tick, it has to be different for us. And the way the therapist shows up makes it different too. So yeah, it all over the place.
So let's say someone just comes in, they're freshly detoxed, they're in the partial hospitalization program. What happens? Like, what first happens in therapy? Do you meet one-on-one? Do they go straight to group? What's the process like?
Yeah, so I mean, first thing is we do an assessment. Right? We want to make sure that we are the right people to serve them best, right? And so that's the ethical responsibility. If I can't serve you best, then I should get you in touch with the person who can serve you best. So that's step one. And really from there, that assessment process is in part boring and in part like, who's this guy asking me all these questions?
Deeply personal questions.
Yeah. So should I really be telling you this, right? Like, there's just that stuff that comes up throughout it, but the reality is there's some rapport building, there's some joking on that just needs to go on through that process. And then it's, a lot of treatment starts with paperwork, right? Like, we need consent to do the work that we do. So that is kind of the piece at first where some anxiety sits in, right? It's like, okay, I'm signing this, and it all happens, either feels like eternity or feels like a flash. But then when we're actually in therapy, ideally, like, I don't want someone just sitting around doing nothing. So I'm going to engage them in group as soon as I can of, let's go meet the community.
Do you find that people are generally pretty shy at first and don't wanna talk in the group setting?
I think it's it depends type of deal. What I would say is, overall, it's a pretty normative thing for people to gauge their surroundings and be like, is this a safe space? Which, if that does happen, then I sit there going, good boundaries, right? Like, that is a very healthy thing to sit there. I don't know these people. I would like to see how this works a little bit, get my feet wet, and then I'm going to inch my way in. And so that's just a sign of boundaries as far as I'm concerned, which is totally appropriate. Whenever I introduce someone to the group, it's also like your typical icebreaker questions, right? Like, favorite superhero, what superpower would you want? If you were a sandwich, what sandwich would you be and
That's
why?
That's a good one.
Right.
I have to sit down and think about that.
What sandwich would you be?
I don't know. I'd need to, like, weigh the pros and cons out to figure that out.
Do you want to know mine?
Yeah.
Okay, so I'm hands down peanut butter and jelly. Because one, it's a classic, like, it works.
I'll cede that point.
It also is just like, I feel like a very efficient sandwich. It's got all the major groups that I need for food. It's got all the energy I need. It's got the protein. It's got the fats. It's ready to go. So I'm just like, it's a very adaptable, action-ready sandwich. I'm a PB&J.
I like it.
So when you get yours,
I'll let you know.
You better let me know.
I feel like I'm something, maybe, we're getting off topic, but something a little bit, like, faux fancy. Like, it seems fancy, but when you get into it, it's really just like chicken and bacon or something like that.
Yeah. Which, you can't go wrong there.
Yeah. Two great proteins. And so, icebreakers, people are starting to come out of their shells.
Mm-hmm. And then what actually happens
Yeah.
in group? Yeah. So, what I tell people in group is a lot of what to... And I say expect a lot of different things, right? So in groups, we're really hitting psychoeducation. We're hitting skill building. We also are hitting depth and processing. And that depth is really like, not so much about like the content of what's happening in your life, but like, how is it impacting you? What is it resonating with? What is it not resonating with? And so, group hits on all those areas. Very much so when you're in that partial hospitalization phase, you're getting 6 hours of group a day. It's more focused on that stabilization, the skill building, the psychoeducation. There's definitely the processing that goes into it, but it's more focused on let's equip you with skills. And the way I think about it is like you go to a doctor, right? And I probably don't go to a doctor for a headache, but let's say you went to the doctor for a headache. You want some immediate symptom relief. And so it's not uncommon that people show up in therapy like that. Like they would like some type of immediate symptom relief. And no, I don't have a wand, which would be really dope if I did, that just fixes things. But the skills of like, hey, this is a way that you can cope. This is a grounding exercise that can help you reduce some of that anxiety that's coming up for you right now. This is how you can manage some of those cravings. Those little symptom relief things could be really, really helpful to engage someone and build some of that buy-in and confidence in the process.
So like, oh, this is actually doing something for me. I should probably stick with it.
Mm-hmm. Absolutely.
So what happens when you get one-on-one?
One-on-one. So
different ball game?
Absolutely. One-on-one is always more vulnerable, right?
For sure.
It is the entire weight. It's like this, right? We are holding this conversation. We don't have that spread out between, let's say, 8 people or so, right? So there's more weight on the 2 people. Like we are doing more intimate work at that point. And it is more depth-oriented. Once again, in PHP, it will, of course, still be focused on, like, let's make sure that you're in a stable place before we go too deep, right? We don't just want to go right for it and mix everything up.
So people have a lot of, intense things to deal with. You don't want to kind of, day 2, day 3, bring that up to the surface and further traumatize someone, I would guess.
Absolutely, right? And so, the real part of a therapist is to appropriately challenge the person sitting in front of them. And so an appropriate challenge for someone who's like, I am having a craving of an 8 out of 10 right now, and I want to leave. Like, I'm struggling to just stay put. The appropriate challenge isn't like, okay, tell me about your deepest, darkest secret, though. Right? Like that, no, doesn't make any sense. The appropriate challenge for them is like, okay, what can we do to reduce that craving from an 8 to a 6 right now, and remind ourselves as to why you're sitting in front of me in this moment. What are your goals? Right? So that's the appropriate challenge for that person. So it really is about that and rapport building. Like,
I'm going to tell you those deepest, darkest things. Like, I'm going to have to trust you, Daddy.
Yeah, and like, honestly, we aren't going anywhere if we don't have a good relationship. And the studies will back it up. The studies will tell you they don't care what treatment modality I use if our relationship is weak. If the relationship is weak, they'll be like, yes, of course, use evidence-based treatment. But the evidence-based, like, it cares more about your relationship than it does about, like, did you use CBT or DBT? So it's a rapport building. And then honestly, one of my favorite things to do with a new client is I tell them, like, oftentimes we have 2 camps that come into individual session. One is, I've been holding this in forever and I am about to word vomit, and I give them that space. Another is, I don't know who you are and this feels weird to me. And then I go, okay, let's talk about your interests. What are you into? And then I start learning about their values, and it's just a way of saying, like, let's get to know this person's interests instead of their problems first. And more often than not, people will fall in one of those 2 camps that will get the process going.
Do you find that the word vomit people tend to be, and of course, sweeping broad generalizations here, tend to be more ready for treatment? Or maybe ready's not the right word. Are they more gung-ho about, like, let's dig in, let's get to the nitty-gritty stuff? Or is it kind of equal?
I would say pretty equal, right? Because, like, we have, any camp can have its extreme, right? We can have, I am so guarded that I'm not willing to work on anything, or I'm guarded because I don't know you and I would like to get to know you before I share some of this stuff. And then we can have someone who comes in and is like, yup, I need to talk about this. This has been weighing on me for a long time. And they really want to focus in on that, and that's an appropriate challenge for them. And then we have people that they've held a lot in, and it's pretty disorganized. And it's like, okay, let's put some bumpers up. Let's contain this a little bit, because we're going in a lot of different directions at once. And so it's really like, there's no judgment about it, right? It's wherever people are at is where they're at. And once again, the therapist role is like, I'm here to help you through that process.
Meet them there.
Yep.
Meet them where they are.
Mm-hmm.
So we've been talking about PHP. So how many hours a week is all of this going on?
So 6 hours a day, 5 days a week. So 30 hours a group for PHP. Which I don't know if you know, that's a lot.
That sounds like a lot. That sounds like almost a full work week.
It is. And so generally speaking, PHP, whether it goes through insurance or even through clinical recommendations, really you're looking at about 30 days of PHP. It's not meant as like, right, we tend to recommend 90 days for a commitment, because it really does wonders in terms of relapse potential. But the PHP is not like 90 days where you're doing 30 hours of group a week. That would be
kind of the step down continuum of care where you move on to the IOP program.
Exactly. And so we have our 2 IOPs, right? We have IOP 5, which still happens during the daytime. That's 5 days a week. Creative with IOP 5. And then we have our IOP 3, happens evenings, and that's 3 times a week. And so, right, it's the difference of 15 hours a group versus 9 hours a group. And with that is really people are stabilized, and we really get to go deeper. Right? It's like, okay, let's flex this a little bit. I trust that you have the skills, and we've worked on those together. So I want to change what our appropriate challenge is, and in that change, and like whenever these challenges come up, these goals, it's also like client driven. Like, it's all related to a treatment plan that I'm not just sitting there being like, this is what you're going to work on. It's like, what do you feel like you should work on, and how can I help you with that process? This way, all voices are active.
So you've got them stabilized. They're not constantly thinking, the constant cravings and just right when you walk in. So it's more of that deeper, getting to the foundation of why people are using substances.
Absolutely. The root work, right? Really starting to dig into those roots and be like, okay, we got some of that symptom relief, right? I got rid of the headache. Why is the headache there? What is actually happening, right? So like maybe the doctor gives me the ibuprofen and it works time and time again. But I'm still taking the ibuprofen because there's something underlying. Lo and behold, I'm dehydrated, right? Whatever that is. But that root work is really like, what are some driving forces for you?
So I know before I even entered this space, I had no idea that there were so many treatment modalities that you guys use. It's still kind of overwhelming to me to tick down the list of all the options. What are some of the ones that you and we use here?
Yeah, so a lot of them fall into the cognitive behavioral realm. So cognitive behavioral therapy, CBT, dialectical behavior therapy, DBT, acceptance and commitment therapy, which is called ACT.
Are these all talk therapy forms?
Yep.
Okay.
Reality therapy, that's one that I in particular use, and I educate people on it because no one else really uses it. So I'm like, I'll give you something fresh.
What is it? Tell us about it.
It's just a totally needs-focused therapy, where essentially, like, it states we have these 5 needs. We are predetermined to want to meet these needs. Where our choice comes in is how we meet the needs. So like one of the needs is fun. I have to have fun. I don't get a choice. I will, in one way or another, attempt to meet my need. I may do that by trying to drink and engage with people and feel that belonging with people and do that. Or I could do something healthier and go play basketball, or have a phone call with a friend, or have a conversation with you. Right, so there are different ways that we can meet our need, and it's really based on that premise.
Super interesting.
I like it a lot. It's a fun. It's honestly just like, oh, that's how I want therapy done with me. So I share it with people. And then so right, those are more of our talk therapy based things. And then there's the trauma specific therapy, right? And so we have quite a few people trained in brain spotting here. And brain spotting is a very different experience from a therapeutic perspective. I'm holding up a pointer. Oftentimes, there are other ways to do it, but essentially, brain spotting is this idea of like where you look impacts how you feel. And so, essentially, we lean into the discomfort and we say, okay, I want to work on this trauma that's happened for me, and I will be like, okay, tell me about like what's coming up for you. And maybe people can't name the emotion, but I'll tie them into their physical body. And they'll be like, my palms are sweaty. I'll be like, okay, I want you to let me know when we have that at its most intense. And we lean into it. We lean into the process. And really the idea is, so I invite people to think about it in terms like when we avoid something, we give it so much power. When we invite it in, we say that we have the power to deal with it. And brain spotting would say we have the power to deal with it. Your brain wants to heal itself, and by accessing the right spot in your field of vision where you look, your brain and your like the deeper parts of your brain, your limbic system, things like that, will be readily communicating with your body, and it will go through the healing process that it needs to go through.
So it's actually, if someone's experiencing trauma, if you're talking about something traumatic, their eyes will lock into a certain spot. Am I understanding correctly?
Well, I will guide them to locking their eyes into a spot.
Okay.
Of like trying to find that spot, right? So maybe if I were to be like, oh, in this field of vision for me, that's where I'm feeling anxiety the most right now. Like, okay, so there's something in that spot. Let's use that spot. Let's be in touch with our physical experience, our emotional experience, and our mental experience, and allow for it to happen and be present with it. So it looks different than a lot of different therapies, and it is awesome. Like I love doing that. And so it did start as a trauma specific therapy, but I have used it for cravings. I have not used it, but I've actually heard about people using it for migraines.
Really?
Yep. People use it for anxiety, which I've also done that one. Yeah, there are a host of things it can be used for. I do use it with grief and loss as well. I believe that grief and loss could easily become traumatic, and so, yeah, it's very interesting, very different, but that's kind of where that trauma piece comes in.
It's really interesting. Diana Sandoval, our executive clinical director, has done a couple webinars on it, and it's just fascinating. At first, I was pretty skeptical. I was like, this doesn't sound real. This does not sound real to me. This doesn't sound like a real thing. And I've talking to Diana, and seeing these things like, oh wow, this is actually not as hokey as I had in my brain is what it was.
I was super skeptical. Like, Diana's the one to tell me, like, you should go get trained. And I was like, should I? And so I did. And then, like, we participate in it, right? Like, that's how we get trained, is, like, everyone goes. I experience being the client, doing it, all that stuff. And I'm, at first, just watching a session with someone holding a pointer. And I was like, what? This is just weird. And then I was the client, and I was like, you've got my attention. Like, I just felt my brain processing on a subcortical level where I didn't really care to talk, but processing was happening. I was like, okay, you have my attention now.
The human mind is endlessly fascinating and weird, I think.
Yep.
So we've talked about brain spotting and some trauma therapy. So we've talked about the progression from PHP to IOP. How does the process change over the course of the next few months? So they've done their stabilization in PHP. They're starting to dig into some of the trauma stuff if they have it, or some of those underlying causes in IOP. How does therapy kind of evolve through the whole continuum of care?
Absolutely. So, like, IOP is like, and like every stage of treatment has its purpose, right? IOP is a really cool part because it is intensive, right? You're doing a lot of that work. And then as we really address some of those roots in IOP and we start getting ready for outpatient, things kind of change in terms of essentially you're able to handle more. You're really entering into, you're consistently in the maintenance phase of recovery. And when in that, groups become less frequent. So outpatient, at least in Lakewood, once a week with me. I know you probably want more. No, but
I'm sure they do.
But so 1 hour and a half group a week. I do continue to support with brain spotting if that's what's appropriate for that client. But in OP is really where we go, okay, let's have you engage more with the community. In IOP, in PHP, you're engaging with our primary clinicians to support you. And here we're going, you're in the maintenance phase. We now want you to branch out to a therapist within the community. And really what we're saying is, let's make sure that you can do this, like Aspen Ridge treatment starts to pull away a little bit. You start to pull away into the community. You got the support of the alumni community and everything like that. But that you're trying out new things in the community and you're not dependent on our services. And so as people start to leave IOP, what they'll be doing with their primary clinician is kind of red light, yellow light, green light, right? What are your triggers? When do you know that you're in the clear? When do you have your warning signs? And when do you say, stop, I need support? And so we're working on those things, and we're also working on that part of, okay, let's get you a referral. Let's find someone that you're going to connect with in the community. Let's see what you need to continue to do in terms of your support groups, whether that be Smart Recovery or 12-step or 8-step, whatever it is.
Yeah, I know for me, I definitely saw a shrink for a little bit. You guys aren't offended by the term shrink, are you?
I'm not.
Okay.
I'm also not easily offended.
Okay, good. I saw a therapist for a while after I got done with treatment, and I think it was absolutely critical for me at least to keep doing almost like maintenance training, just to kind of keep myself in check, to keep doing that, because as much as I wish that my issues with substances would just disappear, go away, and I'd never have to think about them ever again, it's still maybe not daily thing, but it's still something I do need to devote some time and effort to, because I like to use the analogy that my addiction is locked up in a cement cage in the back of my head, but it's in there with a chisel trying to get out. And if I don't constantly sort of reinforce those concrete walls with, positive behaviors, being active in a recovery community, reminding myself that I am a little bit different than everyone else, then that guy can sneak out and come get me.
Absolutely, and you're spot on. That's what we want to see from people, right? Is that awareness and that continued effort, and that embracing that recovery is a lifelong process, right? We always put effort in, right? If we look at some of the disease model, what you're talking about aligns with that, right? I have my inhaler with me because I know it could flare up whenever, and so those positive behaviors are your inhaler, right? That's what's going to keep you engaged and keep your lungs healthy. So it's absolutely that. And in the outpatient, as we talked about, that maintenance, in those groups, it's processing, right? That is a sheer processing group. We're together, we're learning from one another. We do have topics, of course, but it's much more that processing oriented. The psychoeducational pieces and skill building is much more organic as it just comes up. And that's kind of the flow of it. And I was actually just talking with someone else. He was just telling me, he's yeah, why would I stop my individual therapy just because things are going well? This is just working for me, and so why stop something that's working? And I was yeah, I totally agree. Why not? You don't need to be, there doesn't need to be an active problem for you to be actively engaged in therapy if you want to be.
I heard someone use an analogy I thought was pretty poignant, that the disease model, the disease theory of addiction, and they referred to addiction as pretty similar to cancer. It's an active progressive disease that will eventually kill you unless treated and put into remission.
Mm-hmm.
And to keep it in remission for many types of cancers, and addiction in this case, it takes chemotherapy or therapy or constant work to keep it at bay so it does not become a fatal progressive disease again. I thought, wow, that really clicked in my head. Oh, that makes perfect sense to me.
Mm-hmm. Yeah, right? Like, keep engaging, keep doing the work. And that's really what our program is designed for, right? Like, engaging you in the right amount of work throughout the course of your recovery, right? And so at the beginning, depending on where you are, or maybe I shouldn't say at the beginning, but given where a certain person is, they may need more engagement, more involvement, more skills, more grounding. And slowly but surely, they leave the nest, right? Like, that's the idea. It's like, okay, you can now do this without me. And that is really, like, I was talking with a professor about this once. I was like, so the goal of our job is essentially, we're trying to have people break up with us. Like, this is a one relationship where, like, every time I get into the relationship therapeutically, I'm like, okay, how do we have it so that there's, like, a breakup where you're eventually at that place where it's like, I'm good.
Is it a bummer? I imagine, after you'd spent, a couple of years working with someone, like, as a human, you got to genuinely sort of miss that interaction. Or are you happy? Like, I did my job.
I'm like, the therapist in me has to say all of the above, right? Like, I mean, this isn't like just like one motion or another, right? Like, it's a combination of. And so anytime that we have a client leaving, I'm like, oh, so that's loss that I'm experiencing and our community is experiencing. And like, once again, I don't get caught up in like, loss isn't necessarily good or bad. It is. And loss is a component of change. And if I'm going to work in people changing their lives, then I pretty much need to be comfortable with loss. But it is weird. Like, roughly, I was sharing with the group, I was like, yeah, I mean, essentially, roughly every 90 days, as cohorts come in and, people leave, new people are in, I'm just like, okay, there's a loss again. And also, there's a new opportunity with new people who need our services.
It's like anything else in life. It's just constant change and adapting to what's going on.
Yeah. Thor says it at some point in Endgame, right? The only thing that's permanent is impermanence.
Great movie, by the way.
I'm like, and a beautiful man, by the way. Like, come on, call it what it is.
He's definitely a good-looking guy.
Yeah. So, I listen to him.
Listen to Thor and Danny and your therapist. Well, we're just about out of time. Thank you so much for taking the time to be with me today to talk about these, super complex and challenging topics.
Of course. It's awesome. You better invite me back.
Yeah, you're a good guest. We'll get you on again.
All right.
Thank you guys for joining us. You come back next week for our next episode. And if you or someone you know needs help with addiction, mental health, or trauma, you can visit aspenridgerecovery.com or give us a call at 855-281-5588. We accept most major insurance. So thank you very much for being here, and we'll see you next week.